Hello again, everyone. This is Adam, and today we're going to be discussing Unit 6 Therapeutic Drug Monitoring. So when talking about therapeutic drug monitoring, we're going to be talking a lot about serum blood levels of medications. And so you'll see a lot of graphs like this. And some of the key points to note here, just to make sure everyone's on the same page, we'll be talking about peaks and troughs a lot. And so peak is going to be basically the highest level that a drug can achieve within the body after a given dose. And then the trough is going to be the lowest level of drug in the body, which, if you only give a single dose, it will be 0. Otherwise, if you were to give repeated dosing, you may see that the trough may be above that. So for instance, if you're looking at this picture here, on the left side, you can see your peak level will be the highest that the drug level becomes after a given dose. You see here the beginning of the dose happens up here, and then you'll eventually hit your trough. And then whenever the next dosing interval occurs, when the next dose is given, you'll see that start to rise back up. So you kind of get a picture that looks a little bit more like the graph over here on the right, where after repeated dosing, you'll see that a peak is achieved, and then after repeated dosing, you'll have a trough, and then the level will come back up and back down. And you'll have that kind of normal vacillation to where as long as the dose doesn't change, as long as the interval doesn't change, and as long as the amount that the body is eliminating doesn't change, you should hit a pretty predictable vacillation there where you have your peaks and your troughs achieving pretty similar levels from dose to dose. And that's what we're going to be called, or what will be called steady state, which we'll talk a little bit more about in just a minute. So in regards to steady state and dosing frequency, it's important to remember that an average serum concentration of a drug can be achieved in a couple different ways. You're able to give drugs less frequently but at bigger doses, or you can give them at smaller doses but more frequently. So again, if you're looking at this chart here, now we've seen this one before, but essentially this black line here is going to be the average concentration of the drug over time. And then you'll see here with these larger peaks here, this is going to be a bigger dose that's given less frequently. So this one's being given every 24 hours. So you see it has a pretty high peak, comes back down to a lower trough than we'll see in the other dosing intervals, and then it has another high peak, and then so on and so forth. You get the same average steady state concentration as you would if you were to give the drug at a lower dose but more frequently. So you can see this one here, essentially being given every 8 hours. So you can see there's kind of 3 dosing intervals between each of the kind of these bigger doses here. So the steady state concentration will be the same regardless. It's just a matter of, in some cases you may want to give a drug at larger doses because I can give them less frequently. So if I can get away with giving a drug 1 time a day, that's pretty convenient for the patient. On the other hand, though, the kind of inherent problem with giving these larger doses at less frequent intervals is that you run more risk for hitting toxicity. So for any given drug, there's going to be a range where they're, at a certain level or above, you're going to be hitting toxicity, and then at a certain level or below, you're going to be hitting kind of sub-therapeutic levels, and thus the drug will not be as efficacious. So you'll see with certain drugs, especially certain antibiotics, that have to be given several times a day, say every 6 hours or so. It's important that they're given that frequently because here we want to make sure that the trough doesn't drop too low, in which case it might allow things like bacteria to continue to multiply and not really get rid of our infection. So every drug will be different, and you'll see that therapeutic drug monitoring kind of helps us hone in on to see what this appropriate range is going to be in drug levels and how we can achieve that with a given dosing regimen. So again, the steady state is essentially going to be the state at which the amount of drug that you're putting into the body is going to be the same as the amount that's being eliminated by the body. And so if you're looking here at this graph, you can see here that this would be oral dosing because the level starts off at 0 and then would kind of gradually pop up to its peak level versus you see with like an IV dose, you'll see it's pretty much an immediate increase in the levels, as kind of what we saw in the last slide. But here, remember that steady state takes some time in order to achieve. Roughly 4 to 5 half-lives is what it requires for a drug to hit to its steady state. And so you see after repeated dosing, over time we'll have peaks and troughs that are increasing as we go along until we're at the steady state concentration, where basically the amount of drug that we're putting in is being eliminated during that time period. So we're achieving a pretty steady amount of drug in the body, and you see this average concentration here being achieved. And so you can change this via lots of different ways. So you'll see that there's some things that the clinician has some influence over and some things that the clinician does not have influence over. Certainly how big of a dose we're giving or how frequently we're giving the drug can affect steady state concentrations, and by that means also changing the peaks and troughs that we're hitting. And there's also some ways that the patient can change that as well. So for instance, if you were to change how well a drug is being absorbed from the GI tract, or if you were to change how well they're eliminating it, that again can affect the steady state concentrations, because we'll see that steady state is really going to be a factor of the dose, the interval, and then also the amount actually getting into the system and clearance as well. So basically, the term of clinical pharmacokinetics is going to really mean the application of these pharmacokinetic principles, the absorption, distribution, metabolism, and excretion, to make sure we're using safe and effective medication use in individual patients. You'll see that in a lot of cases we start off with kind of population averages and population kinetics that we have available in drug references and things like that, but then taking that information and then applying it to an individual patient, because you'll see that every patient can be a little different. They're going to handle medications differently depending on their size, their weight, their disease states, their genetics. Lots of different things can influence this. And so we can do this because we can measure blood levels of certain medications. You'll see there's other ways of measuring the effects of a medication's efficacy. But essentially, what we're doing here when we're measuring blood levels is that we're looking at the drug concentration at the sites of action, and that should be telling us basically what kind of response we're going to be getting, and then also the potential for toxicity as well. So we'll kind of go into more detail, and we'll see what this means in just a bit. So therapeutic drug monitoring specifically is going to be using serum drug concentrations, and then using those principles of kinetics and also dynamics as well, pharmacodynamics, to individualize and optimize the patient's responses to drug therapy. So you may start out with, say, most adult patients will start out with a drug at a level of 1 gram every 8 hours. But based on therapeutic drug monitoring, you may eventually get to a point where you're changing doses and changing frequencies based on patients' individual factors and based on these serum drug concentrations, to where 1 gram every 12 hours might be more appropriate for them. This will help to make sure we're achieving maximum efficacy of the drug while also limiting a lot of toxicity. So it's really important whenever you're kind of assessing therapeutic drug monitoring and serum drug concentrations that we're understanding the potential benefits, the limitations, and then also how we're going to be applying these levels to make appropriate decisions. You'll see that in a lot of cases, the mantra of treating the patient, not the number, is always going to kind of come back to being an important point. So an early definition for therapeutic drug monitoring was to promote the optimum drug treatment by maintaining drug concentrations within this therapeutic range. And so this therapeutic range is really defined as the point above which toxicity is more likely to occur, and then below that range, the drug is likely to be ineffective. Right? So we're going to be shooting for a therapeutic range, and you'll see that for all the drugs that we do therapeutic drug monitoring on, you'll see an effective range. So say, for instance, for phenytoin, which is an anti-epileptic and anti-seizure medication, their goal therapeutic range is 10 to 20 micrograms per ml. And so that is the range at which, for most patients, below that, they may be more prone to having seizures, and above that, they're more prone to having toxicity like increased sedation and ataxia. So that therapeutic range that we're referring to is really found out by looking at studies where we're giving patients doses of drugs, we're increasing concentrations, and determining where the efficacy is, and then also looking at the toxicity. So we'll look at charts like this, which we've seen before, where you're looking at these curves of the patient's effect on the y-axis here, and also drug concentration on the x-axis. And again, like we said with the therapeutic effect, at a certain point you're going to be having 100% effect. Again, that's when all those receptors are being occupied. And increasing the dose any further, you don't really get any additional therapeutic effect, right? So that's why you have kind of these S-curves that occur with that therapeutic line. And then you look at your toxic effect as well. That should hopefully be happening at a higher drug concentration than your therapeutic effect. But then that all goes back into looking at our therapeutic ranges and our therapeutic indexes. So again, we're going to be comparing the therapeutic effect curves versus the toxic effect curves in order to get this ideal range where we can shoot for to make sure the drug is being efficacious while not being toxic. So here would be an example of a medication that has a wide therapeutic index. When looking at the comparison of the efficacy curve here versus the toxicity curve here, you can see that for at a given dose here, this efficacious dose where the majority of patients are going to be receiving a good therapeutic response, a relatively low proportion of those patients are going to be having toxicity. So you'd have to get your dose very, very high before you'd ever really start to see the adverse effects really start to pick up. And so this would be considered to have a wide therapeutic range. So say, for instance, if you were to compare a couple drugs, have a wide versus a narrow therapeutic index, something like a selective serotonin reuptake inhibitor, or things like fluoxetine or Prozac or citalopram or Celexa, those have a wide therapeutic range compared to some of the older agents we were dealing with, meaning that the dosing that you're going to be using for those patients, even if you were to ramp up the dose pretty high for those patients, they're still unlikely to develop a lot of the toxicities you would see with some of the older agents that have a more narrow therapeutic index. So this just gives us more room to play with, and as far as what an efficacious dose is going to be for patients before they really start to develop a lot of adverse reactions. On the other hand, we have a narrow therapeutic index drug here. This would be something like a TCA or tricyclic antidepressant, things like amitriptyline or nortriptyline. Comparing the efficacy curve versus the safety curve, you can see here that this is much more narrow, because at a point where you're starting to have efficacy, and even here you may not have 100% of patients really achieving that efficacy, you're seeing a lot higher incidence of adverse effects. Right, so this means that you have a much narrower range to play with as far as dosing goes before the patient becomes toxic or before they become subtherapeutic. You don't really get as much efficacy out of it. So these are really going to be the drugs that we're going to be focusing on for therapeutic drug monitoring, because we can shoot for this narrow gap based on the serum drug levels that we're achieving in order to make sure we're being efficacious without being dangerous. So it's important to remember when looking at therapeutic drug monitoring that all patients are going to be a little different between one another, and so that even though you have a therapeutic range that says, the patient should be therapeutic within this range without becoming toxic, you'll have people that fall outside of that, and some of it can be due to pharmacokinetic variability or pharmacodynamic variability. So say, for instance, we give a drug at a certain dose, and then that should equate to that drug having a specific concentration at the effect site. And that's the thing that we can actually measure. We can measure the serum blood levels of a drug, and basically that should equate to a certain concentration at the effector site or at the tissues. And then, there's lots of variability there. There could be issues with the patient maybe not clearing the drug as well or eliminating it appropriately as they should be. Or they have problems with absorption of getting that full dose absorbed into the systemic circulation. So there's lots of variability that can occur there. And that's where we're going to see most of the effects of therapeutic drug monitoring kind of coming into play. That's where we can have the most kind of impact. On the other hand, though, you can certainly have pharmacodynamic variability, where even though you're achieving a given concentration, a known concentration at the effect site that's within a therapeutic range, you're still seeing effects that are either they're either super therapeutic or subtherapeutic, meaning they could be either having not full efficacy of the medication, or they could be receiving toxicity or experiencing toxicity because of that. So this could be something like, I know I'm achieving a therapeutic concentration of a drug, because I know that because I've done serum blood levels of the medication, so I know it's in range, but the patient's having excessive adverse effects. Right? So that could be an issue to where they're either having, say, a drug interaction going on, making them more susceptible to those effects. Maybe they have some other medications that are working synergistically to cause adverse effects, or we could have other issues where like tolerance develops and maybe the patient's more resistant to the effects there, in which it would look like the patient is less than efficacious, even though they're at a good drug level. So it's important to remember that variability, because it's going to come back and it kind of generates some important questions when we're trying to assess drug levels and as well as assessing the clinical picture for that patient. So again, looking at this, you can see there's lots of different reasons for variation in response. So not only can things like drug interactions be important, but you also have to look at the patient themselves. So look at things like, are they pregnant? It's obviously going to cause big changes to lots of different pharmacokinetic variables. You have to look at things like their disease states. Maybe that's helping them or hurting them to clear the drug better or worse. Could be changing absorption of the medication. You can see how all of these different factors can play into pharmacokinetics and the dynamics of how well the drug is going to be working for that patient. So it generates lots and lots of variability in that drug response. And so you'll see that this is where therapeutic drug monitoring can come in to play, where we can be looking at these drug levels and trying to kind of personalize the dose to make sure that the patient is receiving the best therapy possible. So just to give a little bit of a history on therapeutic drug monitoring, it kind of got to start back in the 1950s. Basically, they were looking at drug concentrations and see that that it might actually be a better index than just a straight dose to really guide treatment. I can give the same dose to 10 different people and I may get different drug concentrations, and so maybe concentrations might be a better way to help guide that treatment. And then kind of along that pathway in the 60s, they started to see that half of adverse drug reactions are actually being due to standard doses. Realizing that not giving the same dose to every single person may be appropriate based on lots of different factors, like there's disease states and age and weight and all kinds of things like that. Finally, they started seeing that drug concentrations would be expected to provide a better indication of that drug concentration at the actual receptor site, and so could correlate better with the response. So even though I'm measuring a blood concentration of a medication, does not mean that you have that same concentration at the receptor site out in the tissue, but it is a pretty good correlation there, because again, the volume distribution of a drug should be pretty well set, so it shouldn't really change much. So that relationship is maintained unless you had something else going on. But in general, that drug concentration should be a pretty good surrogate for the concentration at the actual receptor site. And so from then on in the 70s and 80s and further, we've had a lot more investigation into therapeutic drug monitoring and how we can apply it. And so you'll see there's a specific set of medications that we will typically do therapeutic drug monitoring on. So some important considerations in regards to therapeutic drug monitoring. It's important to remember that this really applies to a relatively small number of medications. In a lot of cases, even though we could measure a level for any drug, it doesn't really always have a good correlation between the therapeutic effect or necessarily the toxicity. A lot of medications, you'll see that we can look at some direct measures to determine how well they're working. So say, for instance, you have an antihypertensive like an ACE inhibitor or a beta blocker. Well, I can measure the therapeutic effect just by measuring your blood pressure. I can know that if the blood pressure is too high, the drug's not being efficacious enough, or if I measure it and the blood pressure is too low, I know the drug is being too efficacious and we're having some toxicity develop. Same thing would go for medications that affect serum cholesterol. I can just do a blood level to measure your LDL and HDL instead of just looking at the drug level, which doesn't necessarily give me as much information or information that really correlates to anything. Some other medications that have other measures we could look at. Warfarin is a pretty common anticoagulant that's used for things like atrial fibrillation and prevention of stroke and other things like DVT or deep venous thrombosis, prevention of pulmonary embolism, and things like that. But essentially, though, you don't measure blood levels of warfarin. What you can do, though, is look at the INR, or the International Normalized Ratio. INR is basically a measurement of how thin the blood is, or basically how likely it is to clot or not. So say, for instance, we're giving warfarin, usually you're going to be shooting for a range, an INR between 2 and 3. I know that if I come back with an INR of 6, I know that the blood is too thin, more likely to have a bleed and more likely to have toxicity, versus if I have an INR of 1, I know that the warfarin's not working well enough, and I may need to adjust my dose based on that. So even though warfarin kind of falls in this category of drugs that you can do therapeutic drug monitoring on, this is not going to be the case where you're actually measuring a blood level of warfarin. Rather, you're doing kind of a surrogate measurement by looking at that INR. The things we'll be talking about today are specifically medications where you're doing blood levels of the drugs themselves in order to give us a good idea of whether or not we're in that therapeutic range. So good examples of why we do that for these medications would be something like an antibiotic, something like an aminoglycoside. You have an infection, I'm going to treat you with an aminoglycoside antibiotic, and it may take some time before I really know whether or not the infection is clearing. But what I can do is look at the therapeutic level and make sure that you're within that range to make sure that, one, you're not going to be more prone to having toxicity like ototoxicity or nephrotoxicity. But what I can do as well is look to make sure you're in that therapeutic range to make sure that the level is high enough that if you do have a susceptible infection, it should be treating it appropriately. Other things that will fall into this category are going to be anti-epileptic drugs as well, to where the efficacy may not be fully apparent because a lot of times in those cases you're just waiting for a seizure to happen, and who knows when that could happen. It could be days, could be weeks, but by knowing that we're within a therapeutic range, there's a pretty good idea that we are preventing a seizure from occurring. Just may be very difficult to tell whether or not it's happening. So that's why we look for those therapeutic ranges. So some assumptions you have to make with therapeutic drug monitoring, the first of which being that by measuring drug concentrations, that's going to help provide us an opportunity to adjust for pharmacokinetic variability within patients and to help individualize the dose. So it needs to be some kind of pharmacokinetic kind of consistency with the drug to being where if I change the dose or I change the frequency, there's going to be some fairly predictable changes in actual blood levels that give me that, the ability to individualize that dose for that patient. The second one being that drug concentration is going to be a better predictor of response than just the dose that I'm giving. Because of that pharmacokinetic variability between patients, even though I give a standard dose to, say, 10 different patients, doesn't mean I'm going to achieve the same drug concentration in all of them, right? Lots of factors are going to play into that. So by actually measuring the drug concentration, that's going to give me a better idea of what kind of response they're going to have because I'll know whether or not I'm in that therapeutic range. And then a third assumption should be that there's a good relationship between the drug concentration and the pharmacologic response. So I know that by increasing my dose of a drug, I should see an increase in the pharmacologic response. If I don't see that, there's no good correlation there between the actual drug concentration and the kind of efficacy that I'm getting, then this wouldn't be a good candidate for therapeutic drug monitoring. So as I mentioned before, when we're looking at drug response, there's a number of factors that come into this and kind of whether or not we fit within that therapeutic range. So again, the exposure, how much drug the patient will be exposed to is going to be a factor of, one, the bioavailability of the drug or how much they're actually absorbing into the systemic circulation. It's also going to be based on the clearance of how well the patient's actually clearing the drug itself. So if clearance is not good enough, say they have renal insufficiency, that's going to lead to overexposure, in which case we might be more prone to hitting outside of that therapeutic range and getting into some toxicity. Those are things that the clinician really does not control. We can't really affect how well the patient's going to be absorbing the drug. In very rare cases can we adjust how well the patient's clearing the drug. Maybe some instances like where we can institute hemodialysis, but that's pretty rare for most patients. Other things that we can do to actually control the exposure that the patient gets is going to be by changing the dose the patient receives and also by changing the interval. So again, by giving a drug, say, more frequently, at a lower dose, I can get kind of a tighter control on the peaks and the troughs, and I may be able to keep ourselves in the therapeutic range versus if I give a bigger dose less frequently, so I'm given a higher dose just once a day, you're going to see much higher peaks and troughs, which may lead to either sub-therapeutic levels, which are not good for some drugs, or you can end up achieving toxicity in some cases. So we have control over those variables, and that's where you'll see therapeutic drug monitoring coming into play, because we'll be individualizing the dose and the interval the patient receives to try to take into account the things that we can't control, namely the bioavailability and the clearance of the drug by the patient. So it's important when you're interpreting therapeutic ranges and interpreting levels that patients are presenting to you that these are not going to be absolute. So even though, say, a drug has a given therapeutic range of 10 to 20 micrograms per ml, doesn't mean that just because they're at a concentration of 8 doesn't mean that they will not be achieving efficacy. And just because they're at a level of, say, 15 does not mean that they will not manifest toxicity. It's all based really on probabilities, where they did big studies looking at a number of patients to determine what ranges they were all sitting at and which ones were considered to be efficacious without really having a whole lot of toxicity. So you're going to have patients that fall outside of that all the time just due to their variability, and it could be a lot to do based on that pharmacodynamic variability, to where they may have certain dispositions to where they are more prone to toxicity or less prone to having efficacy at a given level. And really these ranges, all they do are give us the probability that if you fit within this, that you are relatively likely to achieve a good clinical response, and you're relatively unlikely to achieve a toxic response. So again, just because you have a number that doesn't make sense, it's important to interpret those, but you may have some patients who will fall outside of that. So it's important to treat the patient and not the number, right? So if I have a patient who comes back with that level of 8, they're having good efficacy and they're not having any toxicity, I'm not going to touch that number. I'm just going to leave it alone and let them ride with it because they just happen to be one of those people that fall outside of that range. And other things to consider when looking at those therapeutic ranges is that the studies they were doing, as compared to the world's population, it's a relatively small population they looked at. It's important to look at who they studied it in. Some of these ranges are very old, and so maybe the data they were looking at wasn't really applicable to the entire population you may be treating. So if they were only looking at, say, 30-year-old white males, that's not really going to be indicative of how, say, African Americans might process a drug, or say women process a drug. So it's important to kind of consider the fact that if the study population wasn't representative of who you're treating, then it may not be as applicable as you would hope. And then in some cases, it may be pretty difficult to even ascertain the validity of those published ranges. So again, it's one of those things where medical dogma kind of pops up, and so some of these ranges are just the way they are. We may not have a good rationale for why that is. But it seems to be working, so let's just stick with it. And if it's not broken, don't try to fix it. So that's why it's even more important to make sure every level you get, you take with a grain of salt, because you don't want to make a rash change in dose or frequency when the patient is perfectly therapeutic unless you need to. So to start out down the road of therapeutic drug monitoring, the first thing you want to do is to select your target concentration. Normally you'll see that a lot of drugs have therapeutic ranges, say 10 to 20 micrograms per ml, but typically you want to shoot for a given target concentration, not necessarily a range. So that way you're dosing based on hitting that one specific concentration, and hopefully you'll kind of land somewhere near it. So say for instance your range is 10 to 20 micrograms per ml, shoot for a range or shoot for a concentration of 15, and hopefully you'll kind of end up somewhere around there. First off, you also have to assume that your patient behaves like an average member of the population, and if not, you're going to have to make some adjustments based on that. So say, for instance, your therapeutic range is based on patients who have normal renal function. You may need to adjust your dose if you're dealing with a patient who has renal insufficiency in order to help account for that decrease in elimination. So you may need to either decrease the dose that you're giving or give it less frequently to account for that. But in general, assume your patient behaves like an average member of the population. And then using pharmacokinetic parameter estimates, which again are available in most drug references, you're using things like volume distribution, absorption, things like that. You can then begin to calculate your dosing regimen. So then you want to make sure you're dosing until you end up at steady state. And remember, it's going to take roughly between 4 to 5 half-lives in order to achieve that steady state. So for a drug that, say, has a half-life of 24 hours, then you would need at least 4 to 5 days before you should really be checking levels. Because again, if you do it beforehand, you may be looking at a level that's too low compared to what you actually think it should be based on the dose that you're giving. So it may lead you to falsely increase the dose or decrease the interval when you really shouldn't have, right? Because again, you weren't at a steady state yet. The only exception to this would be if, say, you were to give a loading dose of the medication. You guys remembered when we talked about that before. Essentially, a loading dose kind of bypasses the need to wait that 4 to 5 half-lives to achieve steady state, because you give a dose that is large enough to achieve what your steady state concentration that you want is, and then you're simply giving maintenance doses after that, usually smaller maintenance doses, in order to help maintain that steady state. But if you're just giving a drug at the normal maintenance dosing without giving a loading dose, then you do need to wait until you achieve that steady state, which again is going to be 4 to 5 half-lives. But for some drugs that have a really long half-life, say something like amiodarone, which says can be many, many days, that's why we give a loading dose beforehand in order to help achieve that steady state much more quickly. So you dose until you hit the steady state, and then you do your concentration, you do a serum blood level of the drug, and then you either have one of two scenarios. One, in scenario A, you have an adequate response. Patient is achieving efficacy, they're not having too much toxicity, and then your drug level is within range. You just continue treatment. You don't have to do anything at that point. Scenario B, on the other hand, though, is that you are having a patient who either has a level that is outside of the therapeutic range, and they are having a subtherapeutic response or a toxic response, and then at which point you're going to be basically manipulating the dose or the interval in order to help kind of bring that level back into a therapeutic range in order to help mitigate that toxicity while still being efficacious. So some reasons you might use drug concentrations to help you with managing your patient's medication regimen. One would be to provide additional information that can be used in conjunction with other clinical data to assist in determining the patient's status. So say, for instance, you have a patient who is taking their medication. They say they're taking it as prescribed, but now all of a sudden they're developing toxicity. Well, looking at that, you can use a drug level to help determine whether or not the patient's drug level is actually within range or not, which may give you an idea of maybe they're taking it too often or maybe they're not taking it enough. Whatever the reason may be, that drug level can help you in conjunction with things like physical exams and looking at other labs as well. You should also use drug concentrations for providing the basis for individualized dosage regimens, like we were mentioning before. And then also, you can use them to help determine if pharmacokinetic changes have occurred during treatment for your patient. So a really good example of this would be changes in physiological status. So say, for instance, you have a patient who's admitted to the ICU for suspected sepsis, and they're being treated with certain antibiotics which are cleared renally. And then all of a sudden they have some changes where they get more hypotensive, they get put on vasopressors, and now they're having kind of diminished renal blood flow. This can lead to decreased amounts of the drugs being eliminated and predispose them to accumulating and leading to toxicity. So if you know they've had a physiological status change, say for instance you check their serum creatinine and it's gone from say 1 to 2, that would lead you to use a drug concentration to make sure that they are not accumulating too much of that drug. Other things you could use levels for would be if you suspect a new drug, food, or herbal interaction have occurred as well, maybe changing some of those pharmacokinetic principles in the patient. You can use a level there to kind of double check yourself. And then also you may use drug concentrations to actually check for adherence to medication. So something I hadn't considered before I'd heard about it was when I was in rotations, I had a friend who was taking a rotation in not a substance abuse clinic, but a chronic pain management clinic. And so this is one of those things where patients who were suspected of drug seeking, they would actually do blood levels for, say, for instance, hydrocodone, which is an opioid analgesic. A patient would be complaining of chronic pain, and they would come back too frequently for refills and new prescriptions and whatnot. And so what they could actually do is measure for blood levels of the drug. And if a patient was negative, then they actually knew that the patient wasn't taking the drug at all, but they were probably selling it in order so they could buy whatever drug they did like to abuse. So it was one of those things where you can actually check to make sure your patient is actually taking the drug by using blood levels. Other common reasons to request a drug concentration: if you suspect a toxicity is occurring, if you suspect there is a lack of therapeutic response, if you're checking for adherence, if you are assessing for therapy following changes in dosing regimen. So say, for instance, you checked the level previously, it was subtherapeutic, and now you have increased the frequency with which they are receiving that medication. You should check a level in order to make sure that they are now within the therapeutic range. If there are major changes in clinical status with the patient, or if you're thinking of a potential drug interaction that has occurred. So there's some information that is required prior to interpreting a serum drug concentration. First one's going to be the time the blood sample is actually taken. And that's really important because it should be acquired in addition to the time the dose was last given. That can be really important if you're checking for trough or peak level concentrations. If say the nurse is supposed to be getting a trough level and she draws it, say, 4 hours before the next dose is given, well, that would lead you to think that the trough is too high. But if you at least had that data to know that, okay, well, the level is drawn too early, you can make some calculations in order to help account for that. But essentially, you need to know the time the blood sample was taken and the time the dose was last given. You should also know the dosage regimen to try to figure out, when a level, how long ago since the dose it was when it was received or when the next dose might be received. And then some information about patient demographics. Lab values and things are going to be important as well, things like renal function and hepatic function in some cases. Concurrent medications, especially ones that may be interacting, and then also reason for monitoring. Like, why are you looking for this level? Have you changed a dose recently, or are you suspecting toxicity? That can be really important for helping you interpret that level. And then also what the desired pharmacokinetic or therapeutic range will be for that medication. This can be important, especially with drugs that may have multiple ranges. So say, for instance, you have a drug like vancomycin, which is an antibiotic used for gram-positive infections. For certain indications, you may only be shooting for a level of 10 to 15 micrograms per ml, versus more severe infections, you may shoot for 15 to 20. So again, that may depend on some of the patient demographics and some of the other things that are going on clinically for the patient. So some common characteristics that you'll see with the drugs that you'll use therapeutic drug monitoring on is, one, they're going to have no real clear observable therapeutic or toxic endpoint. Again, you have a range where you can suspect that majority of patients, when they fit into that, they should be achieving toxicity or achieving efficacy without achieving toxicity. But there's really no observable kind of endpoint for that. You'll have some patients who may not be fully efficacious with that medication at the high end of the range, but they're already experiencing toxicity, and vice versa. So that's why you'll find that some patients really just aren't good candidates for certain drugs, because even though they're being maintained at kind of maximal levels, they're still not efficacious, or they're becoming too toxic. You also, hopefully the drug, if you're doing therapeutic drug monitoring on it, the concentration is going to be a surrogate for concentration at the site of action. We talked about that before as being a requirement for this. And then also, usually the things you're going to do therapeutic drug monitoring on are going to have a narrow therapeutic range, which means that they can have pretty variable pharmacokinetics depending on the patient you're dealing with, and that usually are going to be such that the toxicity can be pretty severe, even though the medications really are going to be pretty necessary for treatment. So I'll give you some examples of those in just a bit. We should also, again, kind of go along that last point, the risk associated with toxicity from occurring, and also a risk from lack of response. So say, for instance, you're looking at antibiotics. If I'm dosing it and I'm not achieving a therapeutic concentration, that lack of response can be pretty significant for the patient if they develop a worsened infection, or they end up developing sepsis and potentially death. And then the other thing you want to look at is that they should have a pretty stable pharmacologic effect. Should not really have a whole lot of variability, assuming you keep the concentration the same at any given point. The other things you want to make sure is that the drug assay that you're going to be using should be accurate, should be pretty precise and specific, and you should have a reasonable turnaround time. If it takes, say, 4 to 5 days for a level to come back, it may not be clinically useful, especially if you're dealing with a patient who you may suspect to be either toxic or subtherapeutic. And then hopefully it's going to be relatively inexpensive. Not always the case, and certainly you can get a level for any drug, but the ones we use pretty commonly hopefully will be relatively inexpensive. So here are some medications that are commonly monitored with therapeutic drug monitoring. It's not an all-inclusive list, but probably the more common ones you'll see, at least in clinical practice. First group being anti-infectives. The two big ones here are going to be vancomycin and also the aminoglycosides, namely tobramycin, gentamicin, and also amikacin would fall in this category as well, although amikacin probably isn't used quite as much as these other two. Again, these are medications that if they are subtherapeutic, meaning not in their target range, they could lead to not killing off the bacterial infection, leading to worsened infections, further morbidity and mortality. And then if they are too high, they're above the therapeutic range, you worry about toxicity like ototoxicity, having hearing loss can be permanent, and also nephrotoxicity as well in some cases. One of the big cardiovascular drugs that requires therapeutic drug monitoring would be digoxin, commonly used for CHF or chronic heart failure, or atrial fibrillation to some lesser degree. And then as far as anti-epileptics go, many of them are candidates for therapeutic drug monitoring, but probably the more common ones include phenytoin, carbamazepine, and also valproic acid. And then certainly some immunosuppressants as well, which are important for preventing host rejection of transplanted organs. So tacrolimus being one of the big immunosuppressive agents seen used for that indication. So therapeutic drug monitoring sounds pretty good, but why don't we do it for all drugs? Well, for a lot of cases, the assays are not super readily available, so cost can be a big issue, especially if you're trying to measure a level for a drug that's not routinely done. So a lot of times for some of our more severe, say, seizure patients, a lot of the docs may want to get levels for medications that we don't routinely do, so things like levetiracetam or say lamotrigine, and they're pretty expensive, which can be quite prohibitive, especially if you're doing multiple levels. The other thing with a lot of those drugs are they can also have pretty wide therapeutic ranges, meaning that the levels that you get may not be quite so useful because they may not really be telling you whether or not the patient really fits within a good range for them, where they are going to be efficacious without really being toxic. This also doesn't really work well for drugs where the concentration and then the response relationship isn't really well established. So again, like I said, a lot of those antiepileptics, just because you have a certain concentration doesn't mean that that's really been correlated to either a good response or toxicity or anything like that. And that kind of falls into those that don't really have good reference data available for them. So if you don't really have good references, you can't really determine what a really good range is going to be. And then also drugs that have direct response measures are not going to be useful for this because you can just use those direct responses. So again, like we mentioned with the antihypertensives, it's just a lot easier just to measure blood pressure than measuring the blood level of the drug in question. There are some inappropriate uses for getting drug concentrations. So if we're just obtaining them routinely, even though we know the patient has been therapeutic at the same dosage regimen, has not really had any good pharmacokinetic changes, that's really going to be an inappropriate use because it's just going to tell us something we already know. And then also checking them too often is another inappropriate use. It just adds up to increased cost. Should we always get a concentration for patients who are responding appropriately? Maybe not. Maybe some of those medications you can kind of start off at, say, a pretty standard reference dose, and then based on whether or not they're achieving efficacy or they're experiencing toxicity, you may just go ahead and get a level at that point. You'll see for certain drugs that it's much more important to get a level soon after you start the regimen. So again, those antibiotics I mentioned are pretty important in order to make sure you're achieving that therapeutic level, because again, it can take a while before you really know if the drug's being efficacious or not, because you have to wait for the bacterial infection to clear. Other things, if we are obtaining in patients when no changes in their patient-specific kinetics have occurred, like I mentioned just a second ago, and then also samples that are taken at the incorrect times, because that usually means you're just going to have to repeat the sample later on, and so sometimes that can mean a delay in getting a level back of, say 8, 12, 24 hours in some cases, which may delay changes in treatment that could be necessary. So some of the actual benefits that we've seen with therapeutic drug monitoring in the literature, one, it's been able to reduce the number of patients who encounter toxicity. So again, especially those who are not clearing the drug as well, you can kind of find those patients and change their dose prior to them becoming toxic. More patients have drug concentrations that are within a therapeutic range, meaning you have more therapeutic successes for those drugs. So especially antibiotics, like vancomycin and aminoglycosides especially. Again, this is compared to patients who are being treated without any kind of therapeutic drug monitoring, who are just receiving standard doses. We can also see improved effectiveness of the drugs, reduced toxicity, hopefully decreased length of stay, and then also hopefully we're going to be seeing more rational use of drug concentrations. We're not just going to get a level just to get one. We're actually going to be able to do something with the level once we have it back. And then also it can be more cost effective, especially if you're reducing the number of toxicity people are experiencing. It can be really, really cost effective in the long run. Again, the drugs that have been shown to have studies that have been beneficial include aminoglycosides, theophylline, which is kind of an old school drug we used to use for asthma, digoxin, lithium, and also procainamide, procainamide being an antiarrhythmic drug. So what are the steps in order to perform therapeutic drug monitoring for a patient? So again, one, determine whether you're doing a routine monitoring or specific indication for the level. So again, if they are having a lack of response, a side effect at a therapeutic dose, you need to determine what the reason is you're gaining a level. And then next, you're going to do your blood sample collection. So one, make sure we're doing it at the right time. If we're trying to measure a peak level, make sure we're doing it right after the dose is being given. Or if we're doing a trough level, make sure it's right before the next dose. And then also make sure you're doing the right collection tube. It could be some instances where the tube is not going to be appropriate for the sample you're trying to collect, which may lead to some big issues. So certainly there have been mix-ups where someone was measuring a lithium level, but they used a tube that actually was lithiated and had lithium already in it. So the level came back extremely high, even though the patient wasn't experiencing any toxicity. So again, make sure the right collection tube is being used. Then you're going to do the actual laboratory measurement, and then you want to communicate the results. One of the big things I always note here is that make sure that when someone is reporting back a level to you, make sure you get the units. It's going to be really, really important and lead to a lot of confusion if not done appropriately. So again, a lot of levels are going to be done in micrograms per ml or milligrams per liter, but that's not always the case. You'll see some drugs that are being done in nanograms per ml, some will be done milligrams per deciliter, which can lead to some mix-ups if they are being reported differently than what you would expect. So a really good example of this when I was working at the Poison Center during my fellowship is that salicylates, like things like aspirin, are measured typically in milligrams per deciliter. And so, usually when you're dealing with patients who have overdosed on salicylates, you'd expect a level, anywhere between, say, 30 to 100 milligrams per deciliter. 100 would be very, very significant, something you'd be really concerned about. And when I talked to this hospital, they were reporting a level back to me, and they said, oh, the level's 400. And I'm like, whoa, what the heck, 400? Like, it's crazy high. I was a patient alive. Then I was like, wait a second, what units were you using? And so they were using micrograms per ml. So I said, oh, okay, well, when I convert that over to milligrams per deciliter, that turns into 40 milligrams per deciliter, much less concerning than an actual level of 400 milligrams per deciliter. So it's really, really important to make sure you're communicating your units appropriately. Next, you're going to do your therapeutic management. So you look, not just use the level to make kind of a gut reaction on what to change, but take the whole clinical picture into account. So say, for instance, you get a level that comes back and the level's a little below the therapeutic range, but the patient's starting to look clinically better. They're starting to achieve that efficacy without any toxicity. Is there really a reason to change the level at that point, or change the dose at that point? Probably not. And so once you make your final decision, then you want to optimize the drug treatment. Typically, you either want to modify the dose or the interval. Typically, you want to do one or the other. In some cases, you might do both. And then you'll basically rinse and repeat. You'll go ahead and do another round of dosing until you achieve the new steady state. And then you'll recheck it again and see where they're at. Again, it takes about 4 to 5 half-lives before you'll actually achieve steady state there. So you want to make sure you're dosing for a long enough period of time to make sure you're getting the appropriate level. So the biggest time I run into problems with that, especially with vancomycin, that's an antibiotic. Oftentimes we do not check a level prior to the third or fourth dose in some cases. And so if you were to check a level right before the first dose, it's going to come back low regardless. And so you may be increasing the dose, which may be totally inappropriate for your patient just because you haven't achieved steady state yet. So one of the other big things that a lot of people are researching into is the idea of incorporating pharmacogenetics and therapeutic drug monitoring. The problem with therapeutic drug monitoring is it's pretty reactive for the most part. It's kind of like, I dose a patient with a drug, I check a level, it comes back, and then I react to it. By using pharmacogenetics or looking at the specific genetic differences between my patients, it may actually allow me to be a little bit more proactive when I individualize their drug therapy. So say, for instance, if I know a patient beforehand is going to be a slow metabolizer of the drug, then I may know beforehand that I want to go ahead and give the drug less frequently or at a lower dose. And so this is this idea of pharmacogenetic guided therapeutic drug monitoring. And so here, if you imagine all these patients who have the same diagnosis here, all of them kind of interspersed, and without knowing any kind of pharmacogenetic differences between them, you would assume they're all the same, right? What you wouldn't know, though, is that you would have some patients who may have really good predicted response to a test drug. You may have some who have a poor response or maybe no response, and then some who are at increased toxicity. And all of this could be related to things like changes in the enzymes that are available to metabolize the drug, could be pharmacodynamic changes in the actual receptor sites. Lots of things could be different between these patients. But by using pharmacogenetic tests, you could help to identify these patients beforehand. In some cases, you may use different doses, different intervals, or you may use different drugs altogether, depending on what the differences are. So again, kind of the old school way of doing drug selection is basically you have drug A, try it out, that doesn't work, try drug B, try drug D. If that doesn't work, maybe C. Maybe we'll try D again. Who knows? The problem is it takes time in order to really finally come up with a final regimen, especially for those patients who are kind of difficult to manage for their disease states. Whereas if we could do a little bit more individualized approaches, if we knew from diagnostic tests that they have certain pharmacogenetic predispositions to one drug versus another, you could jump straight to the final point here and get to the kind of the final answer. Again, it can help to save time, hopefully save money once the tests become more ubiquitous and have a faster time to achieving a therapeutic response. So again, this is kind of the way that the future will be going as we move forward. So here's a good case where therapeutic drug monitoring and appropriate interpretation of levels was able to help save us some headaches when dealing with the patient. So this is a case that happened to us during my fellowship. So we had a patient who had been on the same digoxin dose for 15 days and was seen in the clinic and was basically found to be doing pretty well clinically. Clinically stable, not having any issues. And so the provider went ahead and did a digoxin plasma concentration that morning of her visit and reported it back at 3.4 nanograms per ml. Therapeutic range was between 0.5 and 2 nanograms per ml. So now all of a sudden we have a patient who has a super therapeutic concentration and they are clinically doing pretty well. So what are we going to do with this level? What do you think are some possible explanations for why we'd have an elevated serum digoxin concentration? So the first thing you got to do is start to kind of get an idea of what's happening to the patient, what was really going on. So you want to generate some questions to ask next. So first thing you want to do is determine when the drug was last given, right? So, okay, when's the last time you took your dose? Was it this morning? Was it 2 days ago? When was it? And then you also want to interpret that with when the blood was actually drawn. So in this case, the patient said, oh, I'd taken it that morning, and the drug was also drawn just maybe a few hours after that. Also ask the patient what her dosing regimen is. Have there been any changes recently? Did someone up your dose recently or tell you to take it twice a day? Or maybe the patient had a misinterpretation and was taking it differently than what the actual prescription was for. And then you want to ask about any other adverse effects they may be experiencing. So for instance, with digoxin, there's some pretty interesting side effects, including seeing things like halos around lights. They can have kind of yellowing of their vision, which is called xanthopsia. And you would also see a lot of nausea and vomiting. So currently the patient was not experiencing any side effects like you would expect from a super therapeutic level like that 3.4 we saw. So again, remember when we're interpreting this is that the steady state concentration is really going to be based on the bioavailability, which is how much the patient's actually absorbing. It's going to be based on their dose, divided by that clearance, how well they're actually able to clear the drug, and then also their dosing interval, right? So again, we don't really have any control over the bioavailability or the clearance, but certainly we can have some effect on the dose and the dosing interval. So looking at the different components here, one, the bioavailability. Is the patient absorbing more drug than they're supposed to? Probably not. It's really not a case where this would happen, but maybe they're taking more than they're supposed to. Maybe that's what's leading to this higher level. Then also looking at the dose. Is the patient taking more than what's prescribed? Again, this is easy enough just by asking the question. You can also, especially if they have any kind of like mental deficits, you can talk to caregivers and things like that to try to determine whether or not this could be the case. We could look at the clearance. So again, digoxin is a drug that is renally eliminated. So you can also check, in addition to her serum digoxin level, you can check their renal function to make sure that has not gone down drastically since her, say what her baseline is, because that could be a really clear indication for why her level might be higher. And then also look at the dosing interval as well. So are they taking it more frequently than what's actually prescribed? Other things you could also consider, one, looking at an assay error. Perhaps the drug level, the assay was done incorrectly, and that would lead to a higher level than what you would expect. It could be possible. And then also looking at interfering substances, so maybe there's a drug-drug or drug-herbal interaction. In some cases, you can have drug levels being falsely elevated by certain herbal products, which could be interfering. But this was not the case in this circumstance. So now what do you want to do? So now you've kind of asked your questions. Again, the first thing you want to do is help to confirm the sample timing. So make sure that the time the drug dose was given versus when the level was performed. You have that kind of firmly in place. Determine the patient adherence to make sure they're actually taking it like they're supposed to. And then we also want to assess for other concomitant substances, so other herbal products, other drugs which might be interacting. In some cases, you may say, well, let's just do a repeat sample. Let's repeat it and see if that's still accurate, because it could be a case where you had a bad assay the first time. And then again, we're going to be looking at determine the bioavailability, determine clearance. So again, look at renal insufficiency, things like that, to determine if that could be playing a role in this elevated level. So again, would this be an appropriate use of digoxin therapeutic drug monitoring? Again, we have a pretty adequate indication because again, the patient had been on it and started on it. So again, you do want to check a level to make sure that it was within a therapeutic range. Make sure we have the appropriate timing. So that may be questionable because again, if we're checking say a trough level, and we ended up giving a level that was right after the dose was given, then that certainly wouldn't be appropriate. And then also make sure we're rationally interpreting that level when it comes back. So again, adequate indications for digoxin therapeutic drug monitoring would be one, if you're suspecting toxicity or if they're having an adverse drug reaction. So if they were having that haloing around the lights or the yellowing of the vision, that would be a good indication to check a digoxin level. If they've newly initiated treatment, so with our patient, that was the case where she had just recently started digoxin. If you had a dosage adjustment in patients with renal instability, so if they had a clearance issue, certainly you would check a level after changing the dose to make sure they're still appropriate. And then also they're just kind of high-risk patients. They're really at risk for developing arrhythmias and things like that. That might be a patient you'd be a little bit more cautious with and definitely want to check a level on. Again, if you suspected a drug interaction was occurring, either leading to too high a level or too low a level, if you were suspecting an overdose had happened, again, changes in pharmacokinetics, and then also decisions for future therapy. So if you were having a patient who was on a stable dose of their drug and they were still not achieving efficacy, you could check a level and still determine, kind of help you determine whether or not you want to continue that therapy or try something different. So again, interpreting our drug concentration measurements, make sure that we are aware of some things. One, make sure that the drug level we were checking was already at steady state. So this would be more important if the level was coming back too low. That would lead us to think that maybe we checked the sample too early and we should have waited till at least 4 or 5 half-lives has passed. Again, checking our sample timing, make sure that's appropriate. Make sure it's adherent to the therapy as they're supposed to. Make sure the timing of our dose and our sample collection was appropriate. Make sure the blood sampling site was done appropriately. There are certainly some cases where we've had very high levels of things like vancomycin come back, and the reason that was because the nurse was actually drawing the sample out of the line that the vancomycin was infusing in. So, normal therapeutic range that we were looking for was between, say, 15 and 20. Level came back at like 70. This is because she had drawn it out of the line that the drug was infusing through. And then also there could just be some intrapatient variation there where they might be one of those patients who has an abnormal level but is still therapeutic at it. So sometimes you run into issues where drug levels just really don't make a ton of sense. And so there's lots of factors that can kind of go into this. First set being factors related to the drug administration or the blood sampling logistics. So this could be an issue where the wrong dose was given or the infusion rate was incorrect. So say a medication was given over a prolonged period of time, say a drug's supposed to be given over an hour instead of given over, say, 4 hours. And that was during a time where you were measuring the blood levels. That could definitely affect it. If the dose was skipped or the infusion held, and say maybe the communication was not done between nurse to nurse and level comes back extremely low or maybe not detectable, could be because of this. Say the dose was given at the wrong time, but the blood was drawn at the correct time, or vice versa. The dose was given correctly, but the blood was drawn at the wrong time. That could all lead to levels that are not consistent with maybe what you would expect based on the dose you're giving and the patient factors. Again, as I mentioned before, you could have issues where the sample is taken through the actual administration line, where the drug is still flowing through, which could lead to really high levels. Could have issues where samples are taken from the wrong patients, especially if you have multiple patients in a room, or if you have patients who have moved rooms, things like that can be issues. You have problems with sample handling issues, or maybe a blood sample needs to be kept on ice. Maybe it was kept at room temperature, which may affect your levels. And then also it could be in the wrong collection tube as well, like I mentioned with the lithium example. Could have some factors related to the kinetics of the drug. So say the patient pharmacokinetics fall outside of the population averages. That could definitely be a good reason why a level may not make sense. A sample is drawn prior to steady state. That could be one of the number one reasons why drugs are inappropriately increased in dose or increased in frequency. It's because the sample is drawn too early relative to steady state. And then the blood drawn at inappropriate time based on the drug pharmacokinetics. One of the things you'll see is that some drugs actually have a distribution phase where it takes several hours for them to achieve a steady state kind of tissue to blood level based on their distribution kinetics. And so you'll see that certain drugs need to wait after a certain period of time before you can say that yes, this is an accurate level once that distribution phase has occurred. Some factors could be related to the laboratory, so certainly if the wrong drug is assayed, there can be an issues to where, say, tobramycin is being given to the patient, but gentamicin is measured on accident. Could have some interference with endogenous substances. Certainly, there's been issues where there could be competing substances that will still trigger the assay. I know one really good example was there were some mothers who were in the hospital, had recently given birth, and the babies basically were receiving this this moisturizer that when put on their skin, because we mentioned in the pediatrics lecture that the neonate skin is very thin, that they were actually testing positive for marijuana. So all of a sudden these babies are being taken away from the mothers because they thought the babies were exposed to marijuana or THC. So they went back to the moms, tested the moms are negative. So what it turned out to be was that there's a component in this lotion that when absorbed actually triggered an assay positive for THC. So again, could have interference with odd substances that may lead to inappropriate results. Could have issues with improper or prolonged storage, or you could have technical errors of the assay, which can lead to inappropriate levels. So going back to the case we were talking about, one of the things to note with digoxin is it actually has a 6 to 8 hour distribution phase. So levels that are drawn during this period actually will appear falsely elevated. So in this case, when further asked, the patient had taken the dose 2 hours prior to the sampling. And then when they repeated the level at 6 hours, it came back down to 1.1 nanograms per ml, which was within range. So at this point, no further intervention was needed for that patient. But it just goes to show you that having a good knowledge of the drugs and being able to interpret those levels can sometimes save you some hassle in changing doses and whatnot. So anyway, so again, therapeutic drug monitoring is using these serum drug concentrations and using the principles of kinetics and dynamics to help individualize patient responses to drug therapy. And so it's really important to understand the potential benefits, but also realize the limitations and how to apply these drug concentrations appropriately. And if you have any questions, feel free to let me know, and I'll talk to you guys next time.